All right, did Darla join us? For some reason, the color is off.
This is really dark.
Yeah, the picture's really dark.
And it's bright.
I don't know how to check. It looks really dark, but it's not. And you can hear me all right, Lisa? I'm loud enough?
Yes, I can.
All right. So we're going to go ahead and get started. And we'll wait till Angel sits down and gets herself situated. Hello, Angel. So I will go ahead with a little bit of housekeeping. We are on chapter 24 and 25, which is week 17. And what I'd like to do tonight, if we have time, is to start on chapter 26. I know you haven't read it, but I would at least start reviewing it, and you can be following along in the book. And then what I'd like to do, send answers via email so that you can check your work, and then come back to class next week with any questions. All right? At least I might have to have you mute your microphone because of the reverb and the feedback.
Okay, because I can hardly hear you. You
Okay.
keep.
And that's what I needed to know when I asked you earlier, so hold on. Because I don't want to be yelling. Can you hear me?
Yes, very well.
Okay, so I'll put the mic just right in front of me. I don't know who did this. I like how long it is. All right. So Angel, can you hear me okay? Good, because I can't hear you. And Lisa, you can hear me. And Emily, you can hear me. So then everyone can hear me. I'll put it right there.
Is that better? That better?
Yeah.
Mike was.
Yeah, the lady who came in wasn't too sure what she was doing. Okay. So let's start off with, we're getting near the end. We are close to finishing up. And what that means is when I sent you the AAPC exam form early on, it should have been one of the first emails I sent you. And it's an exam application form. It's 2 pages. And I actually filled out one as an example, so a how to fill it out. If you want to email me, I'll send it to you so you know how to fill it out. And when you're done with it, you actually will need to go onto the AAPC website to locate an exam. As I said early on in the class, You can locate one in New Hampshire or Maine or Massachusetts, wherever you decide. Now, I have not been on the website, so I honestly don't know where there is one right now. But we're looking at probably, April, May timeframe. I'd really like to see everyone sit within the first 30, to 45 days after you finish your class. So what's going to happen is once you fill this out, you're going to choose 2 exams because you have to put on here your first preference and your second preference. And there is a deadline to get it to Amy. The exam is part of your course fee. And the exam, actually, it allows you to sit for your exam twice. So if you do not pass the first time for some reason, you get to take it a second time, and it's all part of the course fee. You need to get it to Amy by the cutoff date. And I don't mean the date of cutoff. Give some time so that she can get you scheduled for the exams that you want. So you can email it to her or fax it to her. I think she prefers email if you can scan it in and send it to her, but faxing will be fine too. And you just complete the forms. There's 2 pages, and you get it to Amy so she can get you registered for your exam. Then you will receive a welcome email and a welcome letter, I believe, from the AAPC. It actually signs you up as a member, and you get all kinds of, access to the AAPC website and the forums and the learning communities and the monthly magazine that comes out. So you should be looking at the exams on the website and starting to think about when would you like to sit for your exam. So I'll make a plan over the next week or so to look at the dates again myself and recommend a few dates, okay? With that said, and I will end up repeating this because I've already said it, when we're done this class, you will be taking the pre-test on Evolve. And you probably don't have the exam review on Evolve yet. And that's fine because I usually set it up when we're done this course. Okay? You will go home, and within the week after class ends, you will take the pre-test. Why? Because I want to see what you have learned. That means you're not studying for the pre-test. You are just going and sitting 5 hours and 40 minutes without interruption, just like you would for an exam. You have your books all laid out. It's only the 3 books, the CPT, the HCPCS, and the ICD-9. And you sit for the pre-exam. Now it's on Evolve, so it's on the computer, and it is timed, and it should time out. When you are done, make sure you write down your score. You should be able to print out the results page, but I don't think you get the results page. Yes, you do. Sorry. At least write down what your score, and it will tell you, so many out of 150, because it's, 10 questions from all the different sections. And it's a pre-exam, and it's simulation for the national exam. Once you are done the pre-exam, you will send me your scores. Whether you take a screenshot or whatever, send me an email so I see how you did. Then you will start working in the exam review book, which is that red book that you have. I think it's red or orange. And it says CPC Physician Review Exam. If you don't have it, make sure you let me know. Send me an email, and I'll have to let Amy see where it is, okay? You will start Unit 1 in that book, and you will actually just be working in it every day. The plan is that you get through Unit 1 and at least half of Unit 2 within the week, because you're on your own 2 weeks after we finish class. All right? So then after you get through Unit 1 and half of Unit 2, you take the post-test on Evolve. So this is all happening within a week span of each other. So we finish class. By the same time next week, you will have taken the pre-exam. You start the review of the exam review book, and you do as much as you can up till the same time the following week. And the same time the following week, you take the post-exam. So another 5 hours and 40 minutes. Okay, no interruptions. Then you send me the scores, and then you work on completing that exam review book. And what we do is we come together for review. Okay? So it's basically like you have class, but you're not coming to class. Instead of having class, you're going to take the pre and post exam. Now you can do it during the day or whatever works best for you. I just want you to work it into your schedule that it is, just within a week of each other. So the pre-exam is to see how well you've done after all of this coursework. Then you do the exam review book, Unit 1 and half of Unit 2, and you take the post-exam. Then you complete Unit 2 and all of Unit 3, and we come together for a exam review. Then from there, we actually schedule a mock exam. I usually do that on a Saturday, and we simulate a national exam. So another 5 hours and 40 minutes. Yep. You can only bring your books. I will proctor it just like it would be done for the national exam. So that's what we meant when we advertised this course, that you have 3 simulations. Okay? The first 2 are really on your own. And then the third one, we set it up so that everyone who is able to come for the mock exam has that opportunity to sit for the mock exam. Now, if you don't, we ask that you do it on your own, and it would be done by hand, and then you would take your answers and go put them into Evolve and get your grade. And then by that time, you should be ready to sit for your exam. Now, some students have actually, taken their real national exam before the mock exam because they got signed up sooner. It's just however you feel about it, all right? But we suggest that we do these 3 simulations and we get everyone ready. So if there is an exam probably May time frame, mid to end of May, I would say that would be the good time for everyone to sit for an exam, okay? Please make sure each time you take the exam on Evolve, you write down your grade. And if for any reason you have an issue with Evolve, please do not get frustrated. All right? Just get up, walk away, contact Evolve. All right? Because we have had issues in the past with the Evolve exam for this course. They say they have worked it out, but there's always those far and few between who have a problem. And I don't want you to get frustrated with it. I want you to just contact Evolve. They have a chat option where you can actually sit on your computer and chat with them. And the best thing to do is honestly, in the moment, when it's happening, if you can't get past where you're at, contact Evolve. Because it's harder for me to contact them and say, I have a student who did this, this, and this. It's better to contact them when it's happening. Also, make sure your browser is updated, your Google or your Mozilla, your Quick Player or your Real-Time, Windows Media, all of those. Make sure those are up to date before you sit for your exam, okay? All right, any questions?
I'm just scared.
Don't be. Okay, that's really important that I outlined it, and I probably will outline it again because for some reason from now until the last class, it will be lost. It just happens. I know it. All right, so tonight, the first chapter is chapter 24. I want you to turn to page 682 in your textbook and page 305 in your CPT book. So, this is the urinary and male systems. And we start off with urinary system. And the urinary system is divided anatomically. And it starts off with the kidney, moves on to the ureters, the bladder, and the urethra. Your procedures are on the prostate in either urinary or male genital system. So we're first divided by anatomic, and then we further divide by procedure. As we learned in earlier chapters and earlier systems, this can be incision, excision, and so on. So the first set of codes that we are brought to are the codes for kidney, 50010 through 50593. And you will see that there are endoscopy codes for procedures done throughout. Most of your cystoscopy procedures will have 0 global days. Your cystoscopy is what? It's a visual exam of the urinary bladder using a cystoscope. Your incision codes, you see right there on page 305, 50010 through 50135. I'm going to caution you that the kidney is located in the retroperitoneal area. The kidney is in the retroperitoneal area. And just make yourself a note by kidney that it is located in the retroperitoneal area. And each one will have codes for procedures. When we talk about renal exploration, your kidney diagnostic procedure is 50010. And that's it. No further procedures are performed. The retroperitoneal area diagnostic procedure is 49010. We have one that is what? Emily, can you tell me what 50010 says?
Renal exploration, not. I can't help. I'm gonna mess that. can't even say that. Necessitating other specific procedures. I don't know why I can't say that.
Okay. And what is 49010?
49010 is.
Okay, 49010 is exploration, retroperitoneal area with or without biopsy. And the 50010 is renal exploration not necessitating other specific procedures. So for 50010, we're actually in the urinary system. For 49010, we're in the abdomen, peritoneum, and omentum. One is the actual retroperitoneal area, and the other is the kidney. Okay? So, as we were talking, anatomic site. Okay? Your renal abscess, or abscess, you're going to find there's renal abscess 50020, kidney abscess 50020, and then if we're going to use radiological supervision, we're going to use a 75989. And a retroperitoneal abscess would be 49060. Your procedures underneath this section, we're on page 684 in your textbook. Procedures. The first procedure that we come to is a nephrostomy. What's a stomy? What do we usually mean by stomy? Angel?
It's an opening.
Yes. So we're putting an opening, and if we look at 50040, we see that they're inserting a catheter into the kidney, into one end of the kidney, and one end outside the body. And they would probably do that to what? Drain it maybe, or to try and flush it, or what have you, okay? A nephrotomy is exploration of inside the kidney. There's no definitive procedure, so with this code you want to verify any code edits to prevent unbundling, okay? A nephrolithotomy, 50060 through 50075, would be removal of calculus. And what is calculus usually, Emily? Stones, yes. Some other procedures that we see would be an ESWL, also known as using shock waves to fragment the calculus. We also have percutaneous lithotripsy. This is where there's insertion of a probe to pulverize the calculus. A basket is actually attached to the probe and pulverizes the calculus and then removes it. We also have a PCNL, which is a percutaneous nephrostolithotomy, or a pilostolithotomy, which is simply a removal of kidney calculus. So why did they have to come up with those big long words, right? Just tell me, removal of kidney calculus. And then we move into the excision category. Over on page 306 in your CPT book. Your excision codes are 50200 through 50290. We have a nephrectomy. And a nephrectomy would be a partial or total excision of the kidney, also known as radical. Total is also known as radical. Radical, removal of fascia. A radical would include the removal of fascia, fatty tissue, regional lymph node, and adrenal gland. The nephrectomy medical record documentation, you want to make sure it indicates if it was a partial or a total, if it was laparoscopic or if it was open, and if there were any structures removed. So make sure your documentation is clear. And if it's not, we're going to query the provider, right? So code 50225 describes a complicated nephrectomy because of a previous surgery on the same kidney. When we hear ablation, we might hear it called cryosurgery, 50250. We might hear that it was done by laparoscope using code 50542, or it was a percutaneous ablation using code 50593. Your renal transplant falls under codes 50300 through 50380. This is the backbench work. What do I mean by that? It is the retrieval of the organ, the preparation of the organ, or the transplantation. And when we do this type of work, it can be either on a deceased or a living person. With the transplantation, it could be without a nephrectomy or with a nephrectomy. And if it's a bilateral procedure, we're going to use modifier 50. Okay? So the key words that you're looking for here in your CPT book would be deceased or living, with or without, bilateral procedure, modifier 50. Your introduction codes. Your introduction codes are for aspirations. Your catheters and injections for radiography, insertion of guide wires, tube changes. Usually it's reported with a radiology component. And then we have repair. Over on page 308 in your CPT book. Repair, you will see a pyeloplasty. This is the repair of the uretero-pelvic junction, the UPJ. And here you might see it as a simple or a complicated. You also have repair for closure of a fistula, and that closure of a fistula is an abnormal opening. When we talk about laparoscopy, this is going to be based on the extent. You've heard me talk about code to the furthest extent. Well, for laparoscopy underneath the male system, we look at ablation of renal. So it could be a renal cyst, a renal lesion, a cryoablation, or a percutaneous ablation. So we always code to the farthest extent. And then we move into our endoscopy codes. Our endoscopy codes are divided by an established connection between the kidney and the body exterior, as well as is it a nephrotomy or a pyelotomy. And once we look at that division, we see if it is further divided by biopsy or removal of foreign body and calculus. So you see here that within every system we have further division of different items. it will usually always be anatomic division and then procedure. And those are the two major divisions, but then you'll see it drill down a little further to maybe the purpose. Or what other ones can you think of, Emily? So anatomic division, procedure division, purpose division, maybe age, okay? The ureter. The ureter is anatomic. And then what do we see underneath the anatomic? We see the type of procedure. And what are the two? Incision and excision. Your laparoscopy codes will describe the surgical procedures, and they may be bilateral or unilateral. For your excision codes, you will report the open procedures. That would be your explore or your drain, the insertion of a dwelling stent, the removing of calculus. And then when we talk about or look at the removal of the calculus, we want to know, is it based on location? Is it in the upper third, the middle third, or the lower third? And then we move on to the excision and the introduction. The excision would be a ureterectomy. Say that 10 times fast. This is where the bladder cuff is excised, or there is a total excision. Your introduction codes would report the injections, the manometric studies, and the change of stents and tubes. And a manometric study is a measures of pressure. The manometric studies measures pressure. Over on page 312 in your CPT book, laparoscopy and endoscopy. This is where we would see the laparoscopic placement of the ureteral stent and your endoscopy codes for the procedure through an established stoma. Our bladder codes on page 313. You will see a lot of bundled codes in this section as well. As you've seen throughout the CPT book, you have different sections where you have bundled codes. But for the bladder, you will see many of them. So make sure you read all of the descriptions carefully for the site, the technique, and the reason for the procedure. So in your bladder codes, read all of the descriptions carefully for site, technique, and reason. And again, as we've talked about earlier, we have incision and excision. And if you think about it, it's just like to go out, you open the door, and you close the door. And to come in, you open the door and close the door. So in most every system, you will have incision and excision. Okay? So for incision, you will see cystotomies for lesion destruction, or insertion of radioactive material, or fulguration, which is use of electrical current. Then you have a suprapubic catheter placement. So you have an incision and insert a catheter. Your excision would be cystotomies and cystectomies. These codes will be divided based on the extent of the procedure. Introduction. Introduction are codes 51600 through 51720. You will see injection procedures here for the urethrocytography, and that is going to have a radiographic supervision and interpretation that is reported separately. Also underneath the introduction section, you will have the installation of the anti-carcinogenic agent via a catheter for bladder cancer. Yes, Angel?
Could you repeat that one, the first one with the introduction? I got as far as the radiographic supervision.
Yes, sorry. For the introduction, underneath, you'll see the injection procedures for urethrocytography. And this is where you would have radiographic supervision and interpretation reported separately. It should be in there in parenthetical notes that says this is reported separately. And then also part of the introduction is the installation of the anti-carcinogenic agent, which would be done via catheter for bladder cancer. And you would make a note here that the retention time is included in this code. The urodynamics, these are procedures that relate to motion and flow of urine. So it's motor and sensory function. This is used to diagnose any urine flow obstructions. You will see that it's bundled. All of it is usual, necessary instruments, equipment, supplies, and technical assistance. You want to always code urodynamic code in addition to all other cysto codes if both are performed. And if there are multiple procedures, use a modifier 51. Okay? If there are multiple procedures, use modifier 51. Then on page 315, we have the repair and laparoscopy codes. Under your repair codes, you will see cystoplasty, cystourethroplasty, and that big long one, vesicouretropexy and ureteropexy, which is just lovely long words for urinary incontinence. Under laparoscopy, they stress the incontinence procedures, and you just pay attention. Turn the page in your CPT book. Then we see our endoscopy codes, and this is where we get involved with the cystoscopy, the urethroscopy, and the cystourethropy. You will find many combination codes here. Your notes before the 52000 code indicate what's included. So make sure you're reading your notes before, middle, and end, okay? Your 52000 code is assigned for an IVP if it's appropriate. Your 52005 is assigned for a retrograde pyelogram. And when you are coding for cystourethropescopies with any type of dilation, what do you think are some of the questions you might want to ask? Is it male or female? Is it initial or subsequent? Was it general or spinal anesthesia? Then we also want to check, is there additional time and effort for the second procedure, and what is modifier, do we need to add modifier 22? Emily, can you tell me what modifier 22 is?
It is increased procedural services. Do you want me to read?
Increased procedural services, yes. Why do you think that might happen with an endoscopy or cystourethropy or
Complications. There's always something.
always something? Coding to the furthest extent. And again, is there additional time needed? What have we run into? It's like plumbing,
Yeah.
okay? You start the project and you never know what you're going to run into, right? Transurethral surgery. This involves the urethra and the bladder. This is where you have the TURBT, T-U-R-B-T. This is excision or fulguration of a bladder tumor. Then we have ureter and pelvis. When we're doing surgery on the ureter and pelvis, this would include insertion and removal of any temporary stents.
Where are you at? You lost me somewhere.
We're looking at codes 52400 through 52700. It is the vesicle, neck, and prostate over on page 319 in your CPT book. The vesicle, neck, and prostate. Under the vesicle, neck, and prostate, these codes are for transurethral resection of the prostate, also known as TURP, T-U-R-P. So what we learned before was T-U-R-B-T, which is urethra and bladder. And now we're on TURP, which is transurethral resection of the prostate. If you look at code 52601, you'll see that this is for complete transurethral electrosurgical resection. Some of the other approaches that you'll see reported would be with codes 55801 through 55845. Your 55801 actually reports the removal of the prostate gland, which is a prostatectomy through the incision of a perineum. On page 320 in your CPT book, for the urethra. This is either for male or female. The repair codes would be for a urethroplasty. And again, pay attention to, is it male or female? When they do a urethroplasty, it might be one or more stages. So you would want to see that in the documentation. And then, is there any manipulation? What do I mean by that? It means that they're stretching the narrowed passage. Over on page 321 in your CPT book, the male genital system has subsections. If we turn to page 325 in our CPT book, remember, wherever we have white space, use it to make notes, okay? So I'm not going to go into the anatomy of the male genital system. I think we are all very much aware of it. But what we should know is the format. The subsection format is not that different than what we have seen in previous systems. We start with incision. We have destruction. we have excision, introduction, repair, manipulation, and suture. So our biopsy codes will be located in the subheading to which they refer to. So if they're doing a biopsy on the scrotum, you will find that there is a biopsy code underneath the scrotum subsection. Same thing with the epididymis. If they're doing a biopsy in the epididymis, you will see that under that section. With the penis, your incision categories will differ from that in the integumentary system. Your penis incision codes are for deeper structures, such as the erectile tissue. The destruction codes, they are divided on the extent. Is it simple or extensive? What is the method of destruction? Is it chemical or cryosurgery? And extensive destruction can be by any method, so don't get caught up in it only being one way. Your excision codes will include the biopsy. It will commonly include the biopsy. And some of the commonly used codes under excision will be for biopsy and circumcision. And with your circumcision codes, you want to choose the appropriate code based on the method and the age of the patient. Okay? This is going to be by method and age of patient. A simple biopsy will be 54100. It is also considered a separate procedure. A complex biopsy is 54105. Circumcision will be divided based on if the device was used or not utilized, such as a clamp. If no clamp, it's usually because it's a neonate. And if it's a non-neonate, less than 28 days. So a neonate would be 54160. A non-neonate less than 28 days would be 54161. So we want to know, did they use a clamp or not? Your introduction codes on the right-hand column of page 325 in your CPT book. Again, there will be many procedures for the corpora cavernosum. You will have injection procedures for the Peyronie disease, which is toughening of the corpora cavernosum. And there will be tests for erectile dysfunction. You have two codes that have a global professional and technical component. That would be codes 54240 and 54250. So 54240 and 54250 have a global, professional, and technical component. The professional is the 26 modifier, and the technical is the TC modifier. The use of the appropriate modifier is important when you're assigning it in these codes. If we are in the hospital setting, the physician would use the modifier 26 on the procedure code. Your repair section, you will find a lot of plastic repairs. Some repairs are actually staged, meaning there's more than one stage. If that's the case, you would use modifier 58. Okay? And the stage is actually indicated in the code description. When we have repair of wounds involving skin and subcutaneous tissue of external male genitalia, you want to be using the integumentary section codes. So when we're repairing wounds that involve skin, you want to use your integumentary section codes. The testis, page 327. Underneath the testis, you have excision codes, which you will see biopsy, excision, and orchiectomy. You will also have biopsy, which could be incisional or percutaneous. Your orchiectomy codes will be reported by whether or not it's simple or radical. Is it unilateral or bilateral? Is it with or without testicular prosthesis insertion? And what approach is used? So what approach is used? Also, do we have exploration? Do we have undescended testis? Is it congenital? Is it unilateral or bilateral? Is it associated with a hernia? Your repair codes underneath testis, orchiopexy. This is moving and fixation of testis to the scrotal sac. You might have an abdominal approach or a laparoscopic approach. When you're choosing these codes, it's going to be based on approach. Is it inguinal, scrotal, or abdominal? So pay attention to the approach. Inguinal, scrotal, or abdominal. And pay attention to the CCI edits, because they don't want bundled procedures. Over on page 328 in your CPT book, the epididymis is a narrow, coiled tube on top of the testis. It actually connects the efferent ducts to the vas deferens. There would be an incision and drainage of the abscess or hematoma here. You would use code 54700 for that. Your excision category would be a biopsy of a lesion or spermatocele or a cyst. In the repair category for this section, it would be codes 54900 and 54901. And if you use a if you report an operating microscope, that gets reported separately with a 699990. Over on page 329, underneath prostate, incision, a prostate biopsy would be a needle or a punch. So biopsy, needle or a punch, any approach. When there is a fine needle biopsy and aspiration performed, they want to refer you to the 10021 and 10022 code. Emily, will you look up 10021 for me, please? One zero zero two one.
Sorry.
That's okay.
It's fine needle aspiration without imaging guidance.
And it falls under integumentary?
Yeah.
Yes. So when there's a fine needle biopsy and aspiration being performed for prostate, you're going to refer to the integumentary section. Your prostatotomy will be simple or complicated. This is where they drain an abscess. They are either going via the perineum or through the rectum. Your complicated, they would document the complexity, such as excessive bleeding. Your prostatectomy, two types of codes here. The prostatectomy codes are 52647 and 52648. The two types of codes, one is coagulation and one is vaporization. Coagulation, they would use a laser. You might have contact or non-contact. Laser vaporization is electrical current vaporizing the tissue. You will see that the prostatectomy can be based on approach as well. It could be perineal, suprapubic, or retropubic. So it's based on the approach first and then the extent. Is it subtotal or radical? And then lastly, brachytherapy. Brachytherapy, you have methods of high dose or low dose, and then placement. Is it transperineal or open exposure? The brachytherapy codes are 55860 through 55865. So your brachytherapy codes are 55860 through 55865. So is it high dose or low dose? Is it transperineal or open exposure? Any questions? All right, let's move on to the female genital system. Page 333 in your CPT book. Page 717 in your textbook. No yawning, Angel. The little ones keep you up again?
Too much going on.
I hear you.
I'm getting pest anxiety.
Oh, You're too early to start that. Trust me.
The thoughts.
I know. The female genital system. Where do we start? Oh. Well, let's start with the reproductive system procedures. The reproductive system procedures fall under 55920. This is where we report placement of catheters and needles into the pelvic organs and genitalia for subsequent interstitial radioelement application. Intersex surgery. Intersex surgery falls underneath codes 55970 and 55980. You will notice there are only two codes in this section: male to female and female to male. These are going to be complicated procedures that are completed over extended periods of time. You'll notice or see that they are performed by multiple physicians with extensive specialized training. Now, for the female genital system, we have anatomic division from the vulva to the ovaries. And in here as well, you will see many bundled services. The subheadings that we see in the CPT book, remember our subheadings are in red, are vulva, perineum, and introitus, vagina, cervix, uteri, corpus uteri, oviduct and ovary, in vitro fertilization. Those are the subheadings. Remember, the ones in red are the subheadings. And underneath the first subheading, vulva, you have definitions for simple, radical, partial, and complete. The Skene's glands are coated with the urinary system underneath incision or excision codes. These are a small group of mucus glands at the lower end of the urethra, the paraurethral duct. And underneath these subheadings, you will find the categories. And who knows what those categories are? They are the incision, the destruction, the excision, the repair, and the endoscopy. Pretty simple, right? They keep it the same throughout all the systems. So in the incision category, we start off with the incision and drainage of abscess. And you might see it in the vulva, the perineal area, or the Bartholin's gland. A marsupialization is where a cyst is incised, and you should have a picture in your textbook, I believe. Let me just double check. Not really. If you look on page 718, there's some pictures there, but basically a marsupialization is where a cyst is incised, it's drained, and the edges are sutured together to keep the cyst open so that it will heal. The destruction codes 56501 and 56515, this is where lesions are destroyed by a variety of methods. So you will see destruction equals eradication, not excision. Your excision is the removal. Your destruction is also divided by simple or extensive destruction. The complexity is based on the physician's judgment. Extensive would imply greater physician work or a degree of difficulty or number of lesions destroyed. It would be stated in the record. 56501 and 56515 have a global period of 10 days on the Medicare fee schedule. If the patient returns in 2 for a recheck, it's actually included in the payment for original procedure. Destruction means there's no pathology report. Your excision codes. Excision codes, page 333, right-hand column. Your excision codes is where you will see the biopsy, and the biopsy would include local anesthetic, biopsy, and simple closure. You want a code based on the number of lesions and place the number of lesions on the CMS 1500 in 24G. Codes 56605 and 56606 are, as you see, designated separate procedures. Your 56606 is an add-on code, and it actually describes each separate additional lesion biopsied from the vulva. The code should not stand alone. The vulvectomy is a surgical removal of portion of the vulva, and this one is based on the extent and size of the area that is removed. The extent you will see is either simple or radical. You also, after extent, want to look at the size. So is it partial or complete? If it's partial, it will be less than 80% of the vulva area. If it is complete, it's greater than 80% of the vulva area. So on the operative report, you want to see the extent and the size. Some of your vulvectomy codes will include a lymphadenectomy. If you look at code 56640, this is a unilateral procedure. There is not a code to describe bilateral. So if it is bilateral, you would use a modifier 50. Your repair codes, you will see there are many plastic repairs. Make sure you read the notes that follow the category. If the repair procedure is for the wound of genitalia, you will use the integumentary system code. And your endoscopy codes will be by means of a colposcopy. either with or without biopsy. So on page 334, the endoscopy is by means of colposcopy, and it is either with or without biopsy. The vagina subheading, these codes are divided based on service. So is it incision, destruction, excision, introduction, repair? For the introduction codes on page 335, this would include a vaginal irrigation. You will see in these codes you have vaginal irrigation, insertion of devices, a diaphragm, cervical caps, a pessary. Who can tell me what is a pessary? Angel, any idea what a pessary is? Emily?
Nope.
Lisa?
No idea.
Okay. Well, a pessary is, as you can see by, do they have an example in your book? Let me just take a look. Yes, on page 722. They show you that the pessary is a barrel-shaped object that they actually insert so that a woman's insides can be held in.
Oh, yes.
And it's usually for women who have had hysterectomies and no longer have that control over the pelvic floor muscles. So that's what a pessary is. And so you would report the device being inserted separately by either using your 9907 code or the HCPCS code for cervical caps, such as A4261. Coverage for supplies are going to vary based on the payer. Your Medicare bundles the 99070 into the procedure code, so Medicare wouldn't pay it. And A4261 by Medicare is usually non-covered. Now, if they use a 57180 code, you have a 10-day global period. So next to code 57180, write 10-day global period. The repair codes. Page 335, still in the CPT book, your repair codes. These are for non-obstetric repairs. Your obstetric repairs will use the maternity care and delivery codes. The global period here is usually 90 days. You want to make sure that you review the operative report for specific details that are relevant to accurate code assignment. Your manipulation codes on page 336. You will see here we have dilation. The procedures done here are under general anesthesia or spinal anesthesia. Also, you will see foreign body being removed from the vagina without anesthesia. If that's the case, you want to also include an E&M code. It would not be appropriate to bill a pelvic exam under anesthesia when there are other related procedures being performed at the same session. The example I would use here would be a D&C. Okay? For your endoscopy codes on page 337 in your CPT book, a colposcopy code would be based on purpose. So is it a biopsy or a diagnostic or a LEEP? What is a LEEP? It is a loop electrocautery excision procedure. A LEEP is where you use a heated wire to excise. It's also known as diathermy. Your endoscopy codes would also include the laparoscopic approach to repair any paravaginal defects. And they show you a colposcopy right on page 723 in your textbook. This enables the physician to view an endocervical polyp. They also give you a diagram. Let's see. In your textbook on page 718, top left-hand corner, it's cervix uteri. Cervix uteri is that narrow lower end of the uterus. The services would include endoscopy, excision, manipulation, and repair. So you see it's tucked way up in there. They also show you a LEEP in your textbook. I believe it's on page 724. It's just a little cervical loop. It's a relatively new office procedure. And it's just cauterizing, removing. Your excision codes, page 337, CPT book. Your conization codes. This is removal of cone of tissue from the cervix. This is where that LEEP technology can be used. Your excision codes in the cervix uteri describe the technique and the approach that's used, as well as the component procedures that you will sometimes see included in this code descriptions. The corpus uteri, you will see many complex procedures in here, often very similar wording and code descriptors. So carefully read these code descriptors, okay? Your excision codes over on, let me just double check. Right underneath corpus uteri, your excision codes 58100. You will see here the DNC, the dilation and curettage. This is of the uterus. Usually after dilation, the curette scrapes the uterus. And you see women will have this usually later on in life when they are going through some of their female changes. Doctors might recommend this happening, or when a woman has a miscarriage or an abortion or different things that might happen. Do not report a postpartum hemorrhage service with 58120. Instead, use the maternity and delivery code 59160. Underneath these codes, you will also see many hysterectomy codes. What you want to know with these hysterectomy codes is the approach is one, and the extent. So is it vaginal or abdominal? Is the extent the uterus, the fallopian tubes? What is it? We want to know. With the hysterectomies, you will often find secondary procedures being performed. Do not code the secondary related minor procedures separately, because they end up being part of the procedure. Underneath your introduction codes on page 338, right-hand side, some of the common procedures in here for introduction would be insertion of an IUD. You would report the supply of the device separately. You will also have specialized services such as artificial insemination procedures. These would be used to report the physician component of the service. Your component coding is going to be necessary with catheter procedures for a hysterosonography. Again, you're going to find notes following the codes that indicate radiology guidance component codes. Laparoscopy and hysteroscopy on page 339. The laparoscopic approach is for removal of the myomas or uterus, and the codes are divided by tissue and weight. Usually laparoscopy means through the abdomen. They just go through the belly button usually. Hysteroscopy is through the uterus. It's a surgical laparoscopy with a vaginal hysterectomy. Your oviduct and ovary codes. The oviduct is the fallopian tube. Your incision category contains the tubal ligations. When it's during the same hospitalization as the delivery, the ligation is coded separately. Pay attention to separate procedure codes. If there is another procedure that's performed during the same session, separate procedures are not billed separately, okay? Laparoscopy, 58660 through 58679. These are based on the purpose of the procedure. The laparoscopy codes are based on the purpose of the procedure. If it's only a diagnostic laparoscopy, you want to use the codes in the digestive system, not the codes in the female genital system. Over on page 341, underneath ovary subheading, there are only two categories here. You either have incision or excision. Your incision codes are for the drainage of cysts and abscesses. These are divided on surgical approach. Your excision codes will be your biopsies, your wedge resection, and your oophorectomy. That's another fun word, oophorectomy. Then we have in vitro fertilization on page 342. These are specialized codes that are used by physicians who are trained in the fertilization procedures. These codes are divided by type of procedure and the method used. Your maternity care and delivery is divided by service. So do we have antepartum services? What is the type of delivery? And abortion. So those are the three types of service: antepartum, type of delivery, and abortion. Underneath your antepartum services, we have amniocentesis and fetal non-stress test. Underneath the types of delivery, we have vaginal delivery, C-section, and delivery after C-section. You will find that there are a lot of notes here in the maternity and delivery section. Read the notes. Besides cardiology, I would say these are the notes I would suggest you really, really, really read. You will have codes that describe global services or portions only, such as delivery only. Gestation. Fetal gestation is approximately 266 days, which is 40 weeks, right? So when we say EDD, we're talking about estimated date of delivery. Oh. Estimated date of delivery is 280 days from the LMP, which is last menstrual period. So, fetal gestation, 40 weeks, or 266 days. EDD is 280 days from LMP. And then we have trimesters. The first is the LMP to week 12. The second is weeks 13 through 27. And the third is week 28 to EDD. Your global package and delivery. Usually you have uncomplicated maternity cases, and these would include the antepartum care, the delivery, and the postpartum care. The antepartum is the before birth, the postpartum is after birth. What does your antepartum care include? Well, the initial and the subsequent H&P, blood pressure, weight, routine urinalysis, fetal heart tones, monthly visits to 28 weeks, twice a month visits from week 29 to 36, and weekly visits from week 37 to delivery. Code services not related to antepartum care separately, such as a pregnant female with a complaint of suspicious mole on her left shoulder, okay? Or visits to the OBGYN physician who is providing antepartum care. Service regarding mole, not antepartum care. What does your delivery include? Well, your delivery includes admission to the hospital with the admitting H&P. Management of the uncomplicated labor, right? Vaginal or cesarean section delivery. Any complications would be coded separately. Any placement of internal fetal and or uterine monitors would be included. Catheterization or catheter insertion would be included. Delivery of the placenta. Induction of labor. Artificial rupture of any membranes. Injection of local anesthetic. What would be reported separately would be your fetal scalp blood sampling, the external cephalic version, and the administration of an epidural. And what does your postpartum care include? Your postpartum care would include exploration of the uterus, office visits following the delivery, episiotomy and repair, repair of cervical, vaginal, or perineal lacerations, placement of a hemostatic pack or agent, and normal follow-up care for 6 weeks after delivery, such as hospital visits, office visits. These would not be reported separately. This ends up being one big package that you bill the insurance for. Underneath antepartum and fetal invasive services.
Could you give me a code for that?
59000. On page 343 in your CPT book. Antepartum and fetal invasive services. An amniocentesis is insertion of the needle into the pregnant uterus, and it withdraws fluid. They use ultrasound guidance with this service. When they do that, you want to make sure you use a radiology code. The antepartum services would include stress tests, blood sampling, monitoring, and therapeutic services for the fetus. Your OB ultrasound codes would be found in the radiology section, codes 76801 through 76828. And then over on the right-hand column, for your excision codes, this is the postpartum curettage, removing the remaining pieces of the placenta or any clotted blood. Any non-obstetric curettage, code 58120. And then turn the page to 344. We have introduction code 59200. This is the insertion of the cervical dilator. What does it do? It helps prepare the cervix for an abortive procedure or delivery. Cervical ripening agents may be introduced to prepare the cervix. Usually it softens and opens the cervix to help with the delivery. On page 734 in your textbook, they talk about cervical ripening. They use the Bishop scoring system to assess the cervical ripening. Your repair codes, 59300. On page 344 in your CPT book, your repair codes are only for repairs during pregnancy. So during pregnancy, not delivery or after pregnancy. It's during pregnancy. Your routine global obstetric care starts off with code 59400. 59400 is vaginal delivery. 59510 is cesarean. 59610 is vaginal delivery after previous cesarean delivery, also known as a VBAC. And then we have 59618, cesarean delivery following an attempted vaginal delivery after a previous cesarean delivery. In your textbook, they show you some examples of episiotomies and use of forceps. This is included in the delivery. It is not reported separately. Delivery of twins. Payers differ on this reporting format. Some want a modifier 22, some want modifier 51. When you get out in the big bad world, you're going to have to just ask the payer, what do you want? Do you want a 22 or 51? The abortion services, 59812 through 59857. There is spontaneous, meaning it happens naturally. Incomplete requires medical intervention. Missed is where the fetus dies naturally during the first or second trimester. And septic is a missed abortion with infection. When they have medical intervention, you'll see that there's dilation and curettage or evacuation, which is simply suction removal. Intraamniotic injections, saline or urea, basically to cleanse. And vaginal suppositories, prostaglandin, to help replenish that in the system. Any questions for these two chapters? How are you feeling about the two chapters? What do you think, Emily?
It's a lot.
It is a lot.
A lot.
I have to say, on top of cardiology, I think these two are the next big ones
Right.
as far as, but that's just my personal opinion. All right. Why don't we take 5 minutes to get up, stretch, use the facilities. We'll come back and go through answers and try and get some reports on the next two chapters done. All right, we're all back. Let's start with the textbook, chapter 24, Theory and Practical. Okay, so number one, we should have penis. Number two, integumentary system. Number three, urodynamics. Number four, modifier 26. And if you didn't do the assignment and you don't want to write down the answers, just email me and I'll be happy to send you the answers. Number four is modifier 26. Number five, anatomically. Number six, retroperitoneal. Number seven, nephrostomy. Number eight is staghorn. 9 is E&M. 10 is hydronephrosis. 11 is calculus. And 12 is gender. On your practical, here are the codes, and then afterwards, if you have any questions, we'll go over them. Number 13, CPT 54015 and diagnosis 607.2. 14, 54065, diagnosis 05413. 15, 50200, diagnosis 791.0. 16, 51600, 74430, with diagnosis 59970. 17, 54322, diagnosis 752.61. 18, 55700, 76942, diagnosis 790.93. 19, 53600, and diagnoses 095.8, 598.01. 20, 54200, diagnosis 607.85. So again, number 20, 54200, diagnosis 607.85. Let's go right on to chapter 25 in the textbook, and then we'll go into the workbook. Page 737, Theory and Practical, chapter 25. Number 1, anatomic. Number 2, urinary system. Number 3, pubis, majora, minora, vestibule, and lesser Bartholin's. 4, the physician. 5, faults. Destruction is obliteration or eradication, excision is removal. 6, no. Destruction is obliteration or eradication. 7, vulvectomy. I wonder who came up with these words. 8, extent and size. 9, simple. 10, radical. 11, partial and complete. 25, number 12, practical. 58550 with diagnosis 179. Number 13, 58670, diagnosis 628.2. 14, 58970, diagnosis V59.70. 15, 59510 and 58611, diagnoses 652.21, V27.0, and V25.2. 16,
Sorry, could you repeat those?
number 15,
Yeah.
59510, 58611, 652.21, V27.0, and V25.2. 16, 57280 with 621.6. 17, 56605, 56606 times 2. Diagnosis 184.4. 18, 57170, 99070, or A4266. You could have had either one because either one is a supply code. Number 19, 57105, 20, 57800, 21, 56405, and 22, 57020. All right, urinary and male systems, chapter 24, workbook, page 153, matching. 1 is D, 2 is J, 3G, 4A, 5F, 6B, 7K, 8E, 9C, 10I, 11L, 12H, 13I, 14G, 15A, 16K, 17D, 18J, 19F, 20C, 21B, 22L, 23H, and 24E. "25C, 26D, 27E, 28F, 29B, 30A, 31D, 32G, 33E, 34H, 35F, 36B, 37I, 38A, 39C, 40D, 41C, 42E, 43A, 44B, 45F, 46F, 47A, 48B, 49D, 50C, 51E, 52F, 53A, 54B, 55D, 56E, 57C. 58, 50562, diagnosis 189.1. And again, I'm going to go over the even ones. The odd answers are in the back of the book. 60, 50760, diagnosis 599.60. 62, 52000, diagnosis 599.70. 64, 55725 with 600.3. 66, 52283. 68, 54150, modifier 52, V50.2. 70, 54420. 72, 55860. 74, 54322. 76, 54163. 78, 50650. I'll do the answers to the reports and then we'll go over any questions. Did everyone do their reports?
Except for number 80.
Okay.
My book's in my husband's car.
Okay.
I have his because he come and got my car, and I thought I had all my books, and I don't have my workbook.
Okay. So if you check the answers when you get home and you have questions, email me and we'll set up a call. Number 80, which is report 37, 52204. Diagnosis 188.9. 82, report 81, 55875, 77778, 76965 with modifier 26. So number 82, report 81, you should have 55875, 77778, and 76965 modifier 26. 84, report 83, you should have 54640 with an LT modifier. And diagnosis 752.51. And that's it. How'd everyone do? Okay, let's move on to 25. I love these matching. All right, number 1. And I'm not going to say the numbers, I'm just going to go down if that's okay. I'll start with 1. D, K, H, L, B, E, M, G, C, I, J, A, F, D, E, B, G, C, F, A, J, Q, L, H, O, K, I, M, N, P. 31 is introitus. Colpotomy, colpocentesis, pessary, false, colporaphy, colposcope, general, loop electrode excision procedure, sampling, hysterectomy, true, radiology, diagnostic, oviduct and ovary, transection, ligation, or occlusion, trimesters, number 48 is 12, 13, and 28. 49, EDD or estimated date of delivery. 50 is ripening. 51, E&M. And 52, postpartum. Now I'll go into the even numbers. 54. 52730.
527?
57230.
No, that's okay.
I get dyslexic.
I'm writing it down unless that was one.
Yeah, I see it in front of me, but sometimes.
That's what I do. That's why I was asking.
So 54 is 57230. 56, 56625. 58, 58825. 60, 59001. 62, 59821. 64, 59350. 66, 58285. I'm sorry, didn't I say 66? 68, 56740. All right, report number 20, which is exercise number 70, 58100, with diagnoses 198.82 and 199.1. Number 72, CPT codes are 59514 and 58611. Diagnoses 654.21 with V25.2 and V27.0. In this particular exercise, 58611 is not a separate procedure, it's an add-on code.
That's fine. Okay, no.
So it's meant to be reported in addition to the major procedure, and in this case, it's the cesarean delivery.
Okay.
That's why.
Yeah, I didn't do the CPT code for that one.
Yep. All right. Any questions on any of those? Let me have it.
That was the one question I had. Was that one?
That
you
was
just
it?
answered, yeah.
That was easy. Okay, I would like to go to the workbook, chapter 26, page 172, and let's go over the two reports that are right there. So, report 41. If we go to the back of the book, they're actually making this one pretty easy for us. They're telling us exactly what we need to give them for codes. So report 41 on page 237 in your workbook. And I'll go slow for you, Angel. All right. This is talking preoperative, postoperative is the same. So we're looking for left cervical spondylosis of C5-6, C6-7 with cervical discs. Now they're telling you right off the bat, they want codes for arthrodesis with discectomy. So the first code we want is arthrodesis with discectomy. Well, arthrodesis of what region? It is cervical, right? They're telling you in the procedure performed that it is an anterior discectomy an osteophytectomy for decompression at C5-6 and C6-7 with allograft fusion and Zephyr plating. So we're looking up arthrodesis, cervical anterior with discectomy. Arthrodesis, cervical anterior with discectomy. So arthrodesis in the back of our CPT book. I really need one of those rubber fingers. If you can find one for the exam, that would be a good thing to have. Okay, arthrodesis, page 759 in your index. Cervical, anterior, let's see. We're actually not stopping at the first cervical. We're going all the way over to the vertebra and then cervical anterior approach. See it over there in the middle column? Page 759 in your procedures, in your index. So cervical anterior 22548. Let's look at that. 22548. We go to our tabular 22548. All right, 22548, arthrodesis, anterior transoral technique. Keep going. Arthrodesis, anterior interbody, including disc space preparation, discectomy, osteophytectomy, and decompression of spinal cord and nerve roots, cervical below C2. Which one sounds better? 22548 or 22551?
2251.
Yes, 22551. And it also indicates in the report that it is left. So we would use the LT modifier. So 22551 LT is the first answer. Now, we see below 22551 that we have an add-on code. So before I would even go back into the index, I would look at that add-on code to see if it applies in this situation. So if you read it, do you think it applies to this situation? It says cervical below C2, each additional interspace list separately in addition to code for separate procedure. I think that sounds appropriate because we had C5-6 and C6-7, right? So our second code would be 22552. Because they're giving you the codes they want you to look up in the exercise. So the first one was arthrodesis with discectomy. The second one was arthrodesis with discectomy. The third one is instrumentation. So instrumentation is the third code we're going to look up. What type of instrumentation? Spinal instrumentation. on page 853 in your alphabetic index in your CPT book, instrumentation, left-hand column near the bottom. It says instrumentation, spinal, insertion, reinsertion, removal, and with arthrodesis. Well, we have two choices here. It's either insertion or with arthrodesis. I'm actually going to myself go for insertion because what are we doing here? It says under general, with allograft fusion and Zephyr plating. I don't have enough hands. So if you go over to read the exercise, they talk about how they inserted that Zephyr plating. So I would look up insertion, instrumentation, spinal, insertion, and they give you a range of codes. So I would look at those range of codes starting with 22840. All right, 22840, posterior non-segmental instrumentation. Well, guess what? Right off the bat, it's an add-on code. We can't use 22840, right? Can we?
So it's not 22586.
No. It is, and I'm gonna give it to you because in this particular one, these all have plus signs. But what you have to keep in mind is that underneath that code, it says use 228 blah 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 in conjunction with, and then it lists all of these codes, right? So before you could even choose one of those add-on codes, you need to know if the range of codes that you have up above, 22551 and 22552, are used in conjunction with. So internal spinal fixation by wiring. Well, it's not wiring. We know it's Zephyr plating. All right, next one, 22842. Dual rods with multiple hooks. No. 22843, 7 to 12 vertebral segments. No. 22844, 13 or more vertebral segments. No. 22845, anterior instrumentation, 2 to 3 vertebral segments, list separately in addition to code for primary seizure. Does that sound more appropriate? It does. So now we confirm. Use in conjunction with, and we go through that list of codes. Are the two primary ones listed in there? Yes. 22551 and 22552 are in between 22548 and 22558. So we know our first code is 22551 with an LT modifier. The second one is 22552. And the third one is for the instrumentation, which is 22845. Because it is anterior instrumentation, 2 to 3 vertebral segments. Why? Because it's C56 and C67. Okay? All right. Next one is the allograft spine surgery. So the next code they want is the allograft. I'm going to let you guys get this one.
Does it say morselized or structural?
1 second. Let's see. I would say by reading it, it's structural.
Okay. Thank
And
you.
once you read it, I think you'll agree when you see your book, because it says in the midway, it says, I got down to the Dora on both sides and was satisfied now that the nerve roots were decompressed and I could put the trial in and place the structural bone graft in.
Okay. Structural bone graft.
Good call, Angel.
Thanks.
Yep. Okay, so what do you think, Emily?
20931.
What do you think, Angel?
Do you want the code?
Yep.
20931.
Okay, Lisa?
I have the same.
Perfect. 20931. Good job, ladies. All right, last but not least, they want the evoked potential. So what they're doing here is they're making sure that the person still has sensory potential, right? Mm-hmm. So, evoked potential. Look up the code. Okay, what do you have for that, Angel?
Oh.
No, you just muted yourself.
95930. Thank you.
What do you have, Emily?
I don't have it yet.
Lisa?
I have the same thing.
Okay.
What am I doing?
What did you find?
I got audiometry.
Audiometry?
Yeah.
Did you look up evoked potential?
Yeah, and it told me to see first it said the scene. I can't say that.
Somatosensory.
Yeah.
Okay.
And then
All right. So the code is actually 95927. So you look up, Emily, 95927. And Angel, you tell me what 95930 is.
Visually evoke potential testing central nervous system, checkerboard, or flash.
Okay. And 95927 is what, Emily?
in the trunk or head.
Right. But if you look at 95925, we have to start there. Short latency somatosensory evoked potential study. Stimulation of any and all peripheral nerve or skin sites recording from the central nervous system in upper limbs. Okay? In the trunk or the head. And this is in the cervical region, and what they were doing, and it specifically says evoked potential. That's what you're looking for there, evoked potential. And it says testing central nervous system, checkerboard, or flash. The 95925 is short latency somatosensory evoked potential study. This one is visual because there's the region of the cervical region that they're working on. They want to make sure that the somatosensory is working. So they did an evoked potential. They did a visual, okay? And that's something you would learn over time and query the provider, okay? All right, diagnosis for this is pretty straightforward. The diagnosis is going to be for a spondylosis. What type of spondylosis? A cervical spondylosis. In your ICD-9 book.
Oh, get the right one.
Spondylosis cervical. What do you have, Emily?
721.0.
Angel?
Same.
Lisa? So the diagnosis code would be 721.0. All right, let's look at report 43. It's going to be on page 239, so I'm going to read it out loud. Preoperative diagnosis, lumbar radiculopathy secondary to herniated L5-S1 disc. What is radiculopathy, Angel?
I don't know. That's
Emily?
I don't know. I know what the study is.
Lisa?
No idea.
Okay. When we talk about radiculitis, radiculopathy, okay, we know that pathy is the study of. But in lumbar, in musculoskeletal items or issues, we're always asking the patient, does the pain radiculate, radiate? Does the pain radiate anywhere? Down the shoulder, down the arm, to the knees, to the feet, to the toes, okay? So in this case, the patient is suffering from lumbar radiculopathy secondary to herniated L5-S1 disc. Where is that? L5-S1 is literally right here. It is the very last lumbar vertebrae, and S1 is the sacroiliac joint. Okay? So what's happening, let's just say this is the sacrum, okay? What's happening is the nerves that are attached here, because the disc is herniated, it's pinching those nerves. So those nerves are getting pinched, causing the radiculitis down one or both legs. So we would ask, is it left side or right side? More than the other. In this exercise, it is right. Why? Because they're performing the procedure, they're performing a right L5-S1 hemolaminectomy or hemilaminectomy with excision of the herniated L5-S1 disc. So they are performing a hemilaminectomy. All right? So look up hemilaminectomy and give me the code. Didn't think I was going to make you work so hard tonight, did ya? And hemilaminectomy would be the procedure.
That's where I'm having issues knowing the difference from the procedure to the ICD.
You know it. I know. It's long. It's late.
Two.
Will you say that to me one more time, because I just lost my whole train of thought.
It's a hemilaminectomy.
Okay.
Like, you know, a big hemi truck.
Yeah. It's right there.
6:30.
6 6:30, 20. God, it is late. Are you just looking for the CPT code?
Yep.
Okay.
What do you have, Emily?
I don't know which one to pick. I don't know. I keep reading all of them over and over again, and I just can't figure out which one.
Which one sticks out to you the most?
I don't know. 6015, but I don't think.
Okay. Lisa, which one do you think?
I just had 6:30, 20.
What do you think, Angel? You muted yourself again.
Yeah, I had the 63020, but I think you got to add a modifier. I just haven't figured out which one.
Okay, so I'm going to give you the correct code, and you're all going to tell me why what you chose is not correct. The correct code is 63030 with an RT modifier. So, starting with you, Emily, why is 630 more appropriate than 63015?
Because it's.
Sure you do.
I don't. Let's take a look. One interspace lumbar.
63015. All right. So what I like in here is that they give you this perfect diagram of the lumbar laminectomy, okay, on 365. So 63015 is laminectomy with exploration and or decompression of the spinal cord and or quadra equina without facetectomy, foraminotomy, or discectomy, example spinal stenosis, more than 2 vertebral segments, cervical.
Oh, okay.
Well, first of all, you're underneath the subheading for posterior extradural laminotomy or laminectomy for exploration.
Oh, okay.
Okay, which is fine, but if you go down to 63020, so Angel, you were close with a laminotomy, in parentheses, hemilaminectomy, with decompression of nerve root, including partial facetectomy, foraminotomy, and or excision of herniated intervertebral disc, 1 interspace cervical. So 20 is for the cervical. We were talking about the lumbar here because it's lumbar, right L5S1. And it was only 1 interspace of the lumbar. So Lisa, what you chose was what? Which one again? 63020?
Yes.
So you
I
and
just
Angel
needed to go up
chose.
one more.
Right. So you both were close. What you're looking for is the verbiage that is as close to the exercise as possible. So you just needed to keep going down.
And I looked at the whole page, I could not find exit for some reason.
When I got to quada equina, I knew right then it was wrong.
I knew it was wrong. I think
Okay.
that was the closest that
Okay. Good. I'll let you guys look up the diagnosis for your assignment. Let's turn to chapter 27 in the workbook. Let's look at a report there. Report 85. That's an odd one. Let's do an even one. So number 46, report 86. Report 86 is an operative report. Yay! Don't you love those operative reports? No? Okay.
You want 58, you said?
Which one?
Number 58, report 46. Which one are you doing?
Page 177 in the workbook, chapter 27. Am I too far ahead?
I went too far ahead.
Huh?
86.
Yes, report 86, page 257 in the workbook. Which is 27, right? All right, so this is a preoperative diagnosis. We have blunt trauma with paintball to the right eye. Hyphema of the right eye, secondary to number 1. Recurrent hyphema of the right eye, secondary to number 1. Corneal staining of the right eye, secondary to number 1. Now, I'm not looking for the diagnoses. You guys can do those for homework. The procedure performed was irrigation and aspiration of the hyphema and blood clot anterior chamber right eye. Well, first of all, what are we doing? What is irrigation and aspiration?
What you're doing is cleaning it out
How are they doing it?
with, say, saline water.
So we are removing, right?
Yes.
So it's removal of
Foreign object.
blood clot. Because they tell you blood clot.
Yes.
So removal of blood clot. Blood clot from what? The eye.
The eyeball.
So look it up. Removal blood clot eye. See how simple these are? Sometimes we make them harder than.
Yes.
And we know that edema is a swelling, right?
You just want the CBT code for it?
I do. Do you have it?
Yeah, 65930.
Emily?
I found that one first. I have to keep reading.
Okay. Would we have a modifier?
Let's see. The right.
Correct. RT 65930 RT. All right. Let's look at report 88, number 48. Report 88. Again, I'll let you do the diagnoses for homework. The procedure is removal of retained sutures, anterior cornea, right eye. So what are we doing here?
Moving.
This one's pretty straightforward. They're telling us removal, right? What are sutures?
Stitches.
But they are considered a foreign body.
Oh, that's the part that gets me is stuff like
Yes.
that. I don't.
They are considered a foreign body. So you would do removal, foreign body, from where?
Eye.
From the cornea. Because it's removal of retained sutures, anterior cornea, right eye. And they have to use a slit lamp, don't they?
With or without? Which way? They didn't use a slit lamp with this.
Very good.
So it is 65220.
Do we have a modifier?
What side of the eye is it? Let me see. Right.
There you go. Do you concur, Emily?
I'm just too slow right now.
Well, look at the code.
It is, yeah. I believe so. Would it be 65920?
65920? What is 65920?
Removal of insect material from the anterior segment.
Didn't I give it to you and tell you it was foreign body?
Yes.
What do you have, Angel?
65220.
There you go. The answer is 65220. Forget Emily. It's late at night. She can't think straight. All right. Angel, what is your takeaway from tonight?
Just a lot of information. That's putting it all together.
I thought you were going to say, don't forget book in my husband's car.
Oh, no. I hate the idea of driving that junk home. He's got a 2000, I got a 2005.
Yeah. You know, I'm partial to my car too, so.
Mine's a standard, his is an automatic, so I'm going to be pushing for the clutch
Yeah.
the whole ride home. I've had the car 4 years.
Oh boy. Lisa, what's your takeaway?
Just once again, a lot of reading. You can't just jump at the first answer you see. You just got to keep going down and down until there's absolutely no clue left. It's just right there.
Yes. It is total, like I say, sleuthing. Total, probably what, healthcare sleuthing or coding sleuthing, however you want to call it. It's sleuthing.
Mm-hmm.
Emily.
Yeah, to drink a Red Bull for class so that I can stay awake this time.
Drink a Red Bull before class so she could stay awake.
For this last hour.
And not sit here yawning, so I have to turn around and, because she's making me yawn.
Please don't forget to send me the lecture. While you poor souls are here, I'll be laying on the beach in Florida. So,
Enjoy it. Send us some sunshine.
I hope I can.
So next week is chapter 26 and 27. It is the endocrine and eye. So I want you to keep in mind to do your in-chapter exercises. Catch up on any Evolve exams that you have not completed. You know, come to class as prepared as you can. Obviously, I want you to come with questions. It makes the class exciting and fun. Any questions? Email me. Have a great week, ladies. Thank you for your time.
Celia,
And
I'll
have a great
email
trip,
you.
Lisa.
Yeah, I'll email you because I don't have that review book.
Okay.
I don't either.
Just
I
send
never
me an
received
email
it.
so I can get those off so Amy can get those ordered.
All right.
Okay?
Bye.
All right, bye.
Well.